Good morning, everyone. Bonjour tout le monde. Ani. My name is France Gélina. I'm the MPP for Nickel Belt, and for the last 17 years, I've been the health critic for my party, the NDP. Here today to talk about the lack of progress to get new, often life-saving drugs and medicine available to Ontarians who need them. For new medications to become available to Ontarians, it must first, the manufacturer must apply to have the medication reviewed. Second, Health Canada, known as the Committee to Evaluate Drugs, reviews the drugs to check for its safety, its efficacy, and its quality. Once approved by Health Canada, the drug can be prescribed, but it will not be reimbursed by the provincial government. To get the drug reimbursed, and to add it to the formulary, the province and territories have come together and funded what we call the Pan-Canadian Pharmaceutical Alliance, better known as PCPA. They are the one who will negotiate a fair price for the new drug. Once a price has been negotiated, then it is up to the province to decide if and when they will add it to their formulary, when they will start to reimburse the user. Those are all important steps, and we don't want to take any of those steps away from Health Canada, should do a stringent review. But what we want is for the PCPA to, the people who do the negotiation for a fair price, to do this in a short period of time, to do better resource, to have better collaboration. Basically like what they did during the pandemic, when they were able to review new vaccine and new medication in weeks and months rather than years. To put it into perspective, patients in Canada wait almost 2 years to access life-saving breakthrough medicine, a year longer than in any other developing country, placing us last in the G7 countries. And patients in Ontario are almost last in Canada to gain access to the new medicine. Today, you will hear from people living with epilepsy, waiting for a new drugs to become covered. I would like to invite Mr. Trevor Gordon from the Canadian Epilepsy Alliance. Trevor.
Good morning, everyone, and thank you for joining us. My name is Trevor Gordon, and I'm here today representing the Canadian Epilepsy Alliance, a Canada-wide network of 26 community-based agencies promoting independence and quality of life for people affected by epilepsy. Our member associations provide a range of support services, information, advocacy, and public awareness from coast to coast. More than 300,000 Canadians live with epilepsy, and approximately 1 in 3 of these individuals, around 100,000 people, experience uncontrolled seizures, which can be fatal and lead to significant impacts on quality of life, social interactions, career prospects, educational opportunities, and mental health. A medication called Xcopri is giving new hope to these patients who have not responded to other treatments. Xcopri was approved by Health Canada in June 2023. In August 2023, the Canadian Drug Agency, which Ontario funds to review new drugs, recommended that Xcopri be publicly funded by all provincial government drug plans based on compelling clinical evidence. However, in October of this year, the Ontario government, along with other provinces, instructed the Pan-Canadian Pharmaceutical Alliance to end negotiations for coverage without a deal. That is why we're here today. I will be the MC for this news conference, and I'm honored to be joined by the experts who are here to explain why Ontario should make it a priority to add Xcopri to the provincial drug plan. Joining us on the phone today is Dr. Lisa Lomax. She just came off an overnight on-call shift in Kingston, and we are grateful that she's able to join us. Dr. Edward Werkovich. Dr. Edward Werkovich is a neurologist at the Southern Ontario Epilepsy Clinic and Association of Canadian Epilepsy Specialists. Chris Fisher, who came all the way from Ottawa to share his story today, was diagnosed with epilepsy as a child. He was prescribed Xcopri earlier this year. Adam Sweet was diagnosed with epilepsy in 2019. He's coming up with a year of taking Xcopri. And today we are also grateful to Frances Yelnats, the official opposition, for being here today to lend her support.
Introduce Lisa.
I would like to note that we have provided quotes and statements from physicians, including the Canadian League Against Epilepsy, which represents 200 medical and science professionals. We will begin on the phone line with Dr. Lomax.
Hi, everyone. Thank you so much for your patience as I join you on the phone as I was on call last night participating in the inpatient care. I'm an epilepsy doctor from Kingston, Ontario and Queen's University, and I direct our Epilepsy Centre. I'm also the President-elect of the Canadian League Against Epilepsy. And thank you so much for hearing us today. I've been practicing in the field of epilepsy for 15 years, treated thousands of patients. Epilepsy is super common. 1 in 100 people have epilepsy, and 30% of these patients cannot get control of their seizures. These are previously well people, often who lose their ability to drive, their ability to work, and their ability to care for their families in the way that they wish to. These patients try many medications, sometimes surgeries that can be risky, and sometimes require special devices implanted or special diet. When Xcopri finally became available, I jumped at the chance to treat my patients with this medication, and immediately I saw a drastic reduction in seizure frequency. And 10 to 20% of my patients became seizure-free. All of a sudden, these people who had tried many medications, had been afraid of surgery or had tried surgeries that maybe didn't work properly for them, all of a sudden could drive, could take a larger role in caring for their families, could get their jobs back, and become a part of society in the way that they truly wished to be. Many of them also are at risk for something called sudden unexpected death in epilepsy. Seizures can cause death, and the only way we know to stop that risk or decrease it is to treat the seizures. And all of a sudden, these patients were becoming seizure-free. It's important to note that Xcopri itself may actually help save money too. When we add this medication, myself and other physicians have noticed that we can decrease doses or wean off other seizure medications. So if a patient starts on 3 medicines and we add Xcopri and they can wean 2 of them, the math tells us they're left with only 2 medications, which costs less for the government overall. Moreover, these patients go to the emergency department less, which is incredibly expensive, costing thousands of dollars per visit. Also, these patients can contribute to the world and to society. They can work again and pay taxes, which again contributes to our whole society. As a Canadian, I'm a strong supporter of universal health care. If we do not allow patients who are already marginalized, who already can't work, if we don't allow them access to this important medication, we are promoting a tiered medical system where those who do not have access have even less access. It's also important to note that the Canadian League Against Epilepsy, which I am the current president-elect, has never, in my recollection, supported any seizure medication. As you know, there's a letter written by the group, by the head of our therapeutic committee, really strongly supporting the funding of this medication. And in my recollection with this group over the past 15 years, that has never happened before. This should be a powerful message to all of us saying that these are all doctors. We all take care of patients with epilepsy. We've seen such a difference and we support this medication. In conclusion, at the end of the day, I want my patients to be seizure-free. I want them to work. I want them to care for their families, and I want them to be safe. I want them to not have to go to the emergency department. I want them to not have to undergo surgeries that may be risky for them. This medication seems to be working. It's not perfect. No seizure medication is, but this one is so effective. More importantly, it's cost-effective. By getting patients on this medicine, they have the opportunity to wean off other medications and go to the emergency department less. So from my standpoint, there's no price that can be paid for quality of life and life-saving, which this medication has potential to do. I would like to turn it back over to you, Trevor. Thank you very much.
Thank you so much for being with us, Dr. Lomax. Next, I'd like to welcome Dr. Berkovich to the microphone.
Good morning, and thank you for having me here. I come here as a humble advocate for my patients who suffer with the consequences of their epilepsy. I started my practice in 2013, and since then have accumulated a large list of patients who have difficult to control seizures. We call them refractory epilepsy. As a community epileptologist, I work in small groups of doctors outside of academic centers, and we're managing these patients in our private offices and trying to keep the patients out of the emergency room, as you heard from Dr. Lomax. I've been working hard over the last decade to manage my patients with our teams to try and reduce their hospital stays, emergency room visits, and unfortunately even ICU stays. I would like to illustrate some of the treatment challenges that patients had with uncontrolled seizures, and I'd like to tell you about a case that I've been following since 2017. 64-year-old woman who I met back then. She used to be a cashier, but could not work because of her epilepsy, and it remains on CPP disability. She has a history of epilepsy since the age of 3, along with depression, and underwent a double mastectomy. She only has focal unaware seizures, which means that she just wakes up on the floor or wakes up not knowing where she is, and people often don't even know what she has because she doesn't have the typical tonic-clonic or grand mal seizures. She has mesotemporal sclerosis, and she did not want to have surgery due to the fact that she was fed up with having seizures. She even at one point came up to me and asked to be considered DNR. She's never had a license and has been injured multiple times because of the seizures occurring on a monthly basis. When I first met her, she came on 5 anti-seizure medications, and the average person is only on 1 or 2. I tried switching a few different with no avail. Once I knew about Xcopri being available, we waited for that time after it got approved by Health Canada, as it's been around in other countries for several years. And I was able to finally get it to her, and within the next few months, I was able to cut some of her other medications, as you heard from Dr. Lomax. It's been 9 months since her last seizure, and I've been able to cut 2 of her other seizure medications, and on the way to cut now a 3rd. Imagine if she had this medication 20 years ago. She could have been working and driving and being more productive. She's on disability, which covers her other medications, but despite doing the Exceptional Access Program, there is no coverage for her medications. As a neurologist, I want to be able to use my tools I have at hand, and I want to be able to have those tools to be able to prescribe these medications, not just to add a medication, but often be able to try and replace and remove and figure out if I can improve the person's quality of life. And the problem is that we don't know what the cost of that is. I would have a growing list of patients who I know would benefit from Xcopri, but I'm unable to offer because they can only get their medications through ODB. I can't comprehend being in Ontario and not being able to prescribe a medication which his Health Canada approved. I call on the Ontario government to help establish a pathway to get this medication covered for patients who would benefit from it. Thank you.
Thank you, Dr. Berkovich. Now I'd like to welcome Chris Pitcher to the microphone.
Thank you. First off, I have a vagus nerve stimulator implanted, so my voice may go up and down during this speech. I've come here from Ottawa to express the immense benefit that I've experienced under Xcopri since taking it earlier this year. I was diagnosed and have had medically refractory temporal lobe epilepsy all my life, and since I was a kid, it has continued to worsen. I have had approximately 90 to 100 seizures a year over the last couple of years, but have been on countless anti-epileptic drugs and have even had 4 brain surgeries, which have disconnected and or removed parts of my brain. As I just mentioned, I have had approximately 90 to 100 seizures a year, which is approximately 3.5 to 4 days. Since the full dosage of Xcopri was taken in May of this year, I coincidentally went 44 days without a seizure. That alone is the second longest I've ever experienced. The 3 longest stints I have had since going on Xcopri have been 44, 29, and 25 days, along with 9 days and counting. So the seizures have definitely been decreasing, and it is an incurable disease, which I have found immense benefit from Xcopri, making my day-to-day life and cognitive abilities much easier, given that I also have a neurocognitive disorder from the brain damage experienced from the seizures. I'm sorry, my VNS is going off in case any of that was unclear. Nonetheless, it's going to be costing me thousands upon thousands upon thousands of dollars in order to pay for this. Given that the benefit I have seen with Xcopri, this is a drug that has immense benefit because I have tried countless anti-epileptic drugs, surgeries, which have not done any immense noticeable difference in a positive way. Xcopri has. Thank you very much.
Thank you, Chris, and thanks again for making the journey from Ottawa to be here today. Next, we have Adam Sweet.
Good morning. First and foremost, I'd like to thank everybody for being here today. My journey with epilepsy began in 2019 when my brother found me awake in our living room, awake but unconscious. Since then, I would say that many epileptics would attest to, my life has been turned upside down. Due to health reasons, I was forced to bring myself out of school. I had my license stripped. I have no longer been able to maintain gainful employment. And I no longer have the privilege of feeling just a little bit off. Any moment where I am not in perfect health, I am fearful that a seizure is coming on. And that is why a drug like Xcopri that has such great benefits is something that we need to bring, that needs to have support of the Ontario government. Sorry. Again, thank you for your time.
Thank you very much, everyone. Now we'll open it up to any questions.
As you all know, there are dozens and dozens of medications available for epilepsy. So I'm just curious why the emphasis on Xcopri specifically, and what it is that you think.
I'll take Dr. Berkowitz. Do you want to take that question?
What it is that's different about this medication versus all the other medications in terms of getting approvals and making sure it's available.
Well, thank you very much, Mark, for that question. I'd also ask if Dr. Lomax's still on the line as well. She can help answer this. You're right. There is a lot of medications. The difference in the medications is that sometimes certain people have failed medications, and we want to try a medication with a different mechanism of action. We also want to try a medication that has good data. As I mentioned in my case vignette, this person has failed 8. And the fact that we're able to find a 9th that worked is astounding, because the data shows that that shouldn't occur. That once someone's failed a few medications, they're considered refractory, and the chance of a seizure causing any significant amount of seizure reduction is infinitesimally small. So the fact that we're able to break those barriers and find patients who can respond where we would have said, sorry, there's nothing we can do for you, I think is a good thing. I also would like to have the option. I think just because we have seizure meds, do we scale back to where we were 50 years ago, where we only had 2 seizure meds? Was that enough? Is 3 seizure meds enough? So I think that the whole point is that line gets moved. So just as I mentioned, a carpenter has multiple tools to make a shelf. I want to be able to have multiple tools so I can help my patients.
If I may also comment, I would also like to add that the numbers really support Xcopri. The reason is this. So when we look at clinical trials for anti-seizure meds, most of them offer something called a 30% responder rate, which means about 30% of people have a reduction in their seizures. But seizure freedom is only about 1 to 2%. The clinical trials for Xcopri show that there's a 50% responder rate, which means about 50% of people have a decrease in seizures. And depending on the trial, between 5 and 20% seizure freedom. So already those clinical trials, those numbers tell us that Xcopri is a tiny bit more effective than what we currently have available to us.
Like I said in my speech, I have had 4 brain surgeries. I have been on multiple medications that have not shown any significant benefit. Where the seizures have gone down, they have only gone up over the years. I've had this all my life. Neurocognitive disorder is only making it worse. Xcopri is only making it better, where in 7 months I have had 18 seizures. Last year I had 90 to 100. So it is only continuing to get it better with this medication. Sorry if that was unclear. My VNS was going off. Thank you.
No, that's good. Adam wants to add something.
I just wanted to add something to that, was that since my diagnosis in 2019, I am no longer taking the first anti-seizure medication that I'm taking. I'm no longer taking the second anti-seizure medication that I'm taking. I'm actually no longer even taking the third. So now, today marks the 316th day since I started Xcopri. In those 316 days, I have had 37 seizures. Now, in order to provide my neurologist with the most accurate data possible, I keep a very diligent record of those seizures. And so in the 316 days before I started taking Xcopri, the seizure frequency was almost double of that. And I would also like to add that since being prescribed Xcopri, I have not been prescribed any further seizure medications. In fact, the dosages of those medications that I was taking before I was prescribed Xcopri has actually gone down, which greatly benefits me as an individual who needs the support of the Ontario government. Just as I've mentioned before, the ability to maintain gainful employment is not something that many epileptics have the ability to do. Thank you.
You brought your concerns to a press conference and making your calls. What discussions have taken place with the government to this point, and what has been the response that you've heard?
That would probably...
The best person to answer that question is our president, Laura Dixon. Unfortunately, she is moderating a panel in Ottawa today and was not able to attend. However, she is available for telephone interviews later today if you'd like to speak. But Dr. Berkovich, if you'd like to add anything to that, or Dr. Lisa.
I'm happy to speak to that. So epileptologists in each province have reached out to government officials in their provinces. And the Canadian League Against Epilepsy has come together and penned a letter, which has again been distributed amongst government officials in each province and territory. So we've been very strong advocates. I know I myself have also met with government officials and advocated for funding for this anti-seizure medication. So I think all of us have taken many steps and done our best to communicate our desire to have this funded to help support our patients.
Has it been silence?
He asked what has been the response.
I know that obviously the government has very different, there's a lot of attention pulled in many different directions for funding. So I don't want to say that there's been silence, but I think that there's been some thought about, next steps. All I can say is that the drug isn't funded. And so obviously we have to keep communicating until this drug is funded.
Why was the negotiations cut off in October? Like, what was the reason behind that? Do we know?
I myself wouldn't know. I'm not sure if our president, Laura Dixon, can make a comment on that later. She's available for telephone calls. I don't know if you wanted to make a comment on that, Lisa.
Do you mind repeating the question? I really apologize. I didn't catch all of it.
Was negotiations called off by the province in October?
So sadly, we don't know all of the details, and I wish that I did and I could comment more. We've reached out and really haven't had much of a response. So I can always venture a guess, but it would be a guess.
$3,000 a year. I don't know, that doesn't seem like an enormous amount of money for a medication, but is it the price?
It's always possible that it's the price, and one always wonders. I have to say that $3,000 is, to me, quite small. The cost of an emergency room visit is over $2,000 and can be up to $3,000. The cost of an admission is between $2,000 and $3,000 a day. So funding a drug for a year saves the cost of, even if a patient doesn't go to the emergency department once, then you're kind of breaking even. And already both myself and Dr. Berkovic have seen that our patients are traveling less to the emergency department. So even if you break it down to that very simple math, it's a very cost-effective drug in that way.
My understanding is that the cost is similar to other similarly priced medications. But again, I argue, and you've seen the evidence here, if both myself, Dr. Lomax, and our two patient advocates here, that not only is the cost of the medication, but we've actually even reduced other medications. So there's a cost benefit of reducing the use of other medication.
And that's part of the product monograph. They specifically say you have to reduce other medications. And so automatically physicians are guided to decrease drugs. So it, again, as Dr. Berkovic mentioned, it's a cost-saving mechanism.
Are any other questions for our panel?
Ask about this in question period today?
Not today, no.
Okay.
Thank you, everyone.